Hello, everyone. I believe Karen will be here shortly, and as if on cue,
There
here
she
she
is.
is.
Just waiting for that.
Yeah.
That I got. All right, welcome to another meeting of the Green Mountain Care Board. Before we start today, I want to acknowledge that something's a little different. It might not be apparent to all, but Thomas, who has been kindly taking it upon himself to try to videotape these meetings since the beginning of our time, is being replaced by this little thing. But there is no replacement for Thomas. Thomas Hall, early in our existence, felt it was important, as we agree, to make sure that our meetings were recorded and available to the public. And he has gone to great lengths to do that, and has discovered just how difficult it is to film things and put them in a format that can be readily available to the public. So we've been working through a process of figuring out how we could take this responsibility more clearly upon ourselves and make sure that there is a record of our meeting that is easily accessible to the public. This little device is supposed to solve that problem and make sure that that there are audio recordings of all of our meetings that can be made available to anybody upon request. And who are they supposed to see if they want to? And they see Sam if they would like a copy of any of the recordings of our meetings. So there will be a public record for folks who can't be here. But I want to acknowledge the hard work that Thomas has put in. And thank you, Thomas. And it's nice that you're still here.
Well, it's a pleasure working with you.
Thanks. You have been a real trooper. You've been doing a real public service, and you've brought some levity to our meetings. So thank you very much.
Thank you.
With that, I think we'll move right into our business. The first item is approval of minutes of two different meetings, May 20th and May 15th.
May 10th.
Well, so I don't have my glasses. The good news is I have a eye doctor appointment next week or the week after, so we will.
Move to approve the minutes of Thursday, May 10th, and Tuesday, May 15th.
Second.
All in favor?
Aye.
Thank you. Of course, the fact that May 20th has not yet occurred should have been my first clue, right? Cal? Go ahead.
Can we
Sam.
talk about the single recorder system that we've gone to? That's eliminated a
Now,
lot
is this
of
going to pick up
microphones.
people across the room too
Oh,
when they
yeah.
talk? Okay, cool.
I'm just not sure why it's in front of me and ticking.
So the subject, the focus for today's meeting is healthcare quality. And we have folks here from the Vermont Program for Quality in Healthcare, which is near and dear to my heart, and from the Health Department to talk with us about efforts to measure, report on, and improve healthcare quality in the state. So I don't know, I guess we're doing this format today, where whoever's speaking goes here, and Catherine, I think you're first.
I think we've supposed to be ordered.
Oh, you have?
Is that okay?
I'm the last. That's fine. So, Deb Wilcox, Director of Planning and Healthcare Quality from the Vermont Department of Health.
And I have with me Rich McCoy, who's the Chief of our Public Health Statistics section.
Hi, Rich.
He is the content area expert.
Okay.
So I provided each of you with a copy of a PowerPoint presentation, really just to frame our discussions, and hopefully it is more of a discussion versus just a presentation. So just chime in to ask questions, and if you have questions, I'll ask Rich to answer.
Is there no?
Yeah, here you go.
Oh, here it is. Okay.
And then once I finish with my section, I work very closely with UPQHC. So a lot of what we talk about, we kind of know each other's world. And so as I go through my presentation, I think it will naturally just lead right into what Kathy wants to share with you.
Okay, thanks.
So the overall objectives, based on what I heard from Georgia when she did outreach to ask us to come, I'm not getting it right. We just want to describe the role of the health department with collecting data, reporting, public reporting, and evaluation. Also share some of our preliminary recommendations with you as the board in how we could help support some of the collection, reporting, and evaluation. And then also just do a review of some of the recommendations that came out of the Act 48 stakeholder interviews that I conducted as part of the health department in the fall, some of the overarching recommendations and how it ties into what we're discussing. So in the health department, just to set the stage a little bit, we have 6 different divisions. One of them is the Division of Health Surveillance, and the public health statistics section sits in that division. And as I mentioned already, Rich is the section chief, overseeing much of the work and the analyst in that section. That section, just some of the 3 primary goals that are laid out on this first page. They plan, collect, analyze, report on data to inform public health decisions and to educate Vermonters about public health needs. And the first example that comes right to me when I think about that bullet is basically, because we're deeply involved in the work right now, is with our Healthy Vermonters 2020 publication. Their unit has been really instrumental in putting together the data compared to national data and setting our goals for moving forward. They also prepare and report on a variety of data based on the law and also program-specific needs. And that translates for me into, I have an example of one of the programs where we had new federal funding coming through, and we needed to determine where to place our resources in the state to impact pregnancy outcomes. And based on analysis that was done in Rich's shop, we were able to look at criteria, determine which areas of the state have the highest risk factors for pregnant women, and then put our resources and the new Nurse Family Partnership visiting program into 4 distinct areas of our state. And they also monitor progress and assess the impact of prevention programs. So as far as the data collection, this section creates and maintains original data sources. They also utilize data from outside of the department. On this page, you'll see a whole list that Rich actually provided to me that many of us are familiar with, but the breakfast data, the Youth Risk Behavior Survey, Adult Tobacco Survey, vital statistics, and even doing healthcare provider surveys for physicians are a few examples of some of the original data sources.
And remind me, how often is the breakfast done?
It's ongoing, so we do a sample every month. So it's constantly going through
Every
the whole
month, every year.
Right.
And you're doing all of the, I forget what they call it, the nodules or whatever of it at all times, or are you doing pieces of it with?
We do all the core required modules that CDC provides, and then we have state-added questions that we will rotate in each year as needed. So in a given year, there might be Blueprint might have a need for us to ask questions, or asthma, or the governor's office for highway safety. We will rotate
Care
in.
board.
Well, yep.
And it's a phone survey or in person?
It started out as a phone survey, is now doing both landline and cell phone, since we now have a larger cell phone population. In the coming next 2 years, we will start testing doing a portion by internet. Some states do in person, but those tend to be extremely long and difficult to set up.
So you do a rolling sample all the time, and then at some point you cut it and say, what have we gotten up till now for a given period of time?
That's correct. And we also have preliminary data, so say if there's a public health emergency, flu vaccinations, we can go in and look at preliminary data on a quarterly basis. We've done that in the past when, say, there was a shortage of flu vaccine.
And then how often do you publish a full set of results?
We will publish an annual report, and then on a monthly basis, we will publish little mini reports on specific topics on a monthly basis. But in terms of, say, what we're publishing right now, we would be publishing the 2011 report about now.
Put us in the mailing list, please. Thanks.
So data that we access and utilize that does not originate in the health department, there's a list on this next page, the hospital discharge data, emergency department data, the census data, and then we are currently applying for, I believe we're still in the application phase of applying to have access to the VCURES data.
For the one?
The VCURES data?
VDA should have access to VCURES data. I think you cited to me.
But we still needed to fill out some of the paperwork and have the staff sign the confidentiality agreements, et cetera.
I think we're getting pretty close though. to the
So,
end
we're
of the process.
submitting the paperwork either this week or next week.
Let us know if you have problems. We like sharing features.
Okay.
But it's not ours.
We also have our own registries and databases that we support and maintain. And examples of immunization registry, the cancer registry, the birth defects registry, and then also the prescription monitoring system.
As far as public reporting, a lot of our data analysts found in the department are funded through federal means. Is shared with other agency partners and with community partners. Examples of public reporting, there's a large variety even beyond what is listed here on this page. The Healthy Vermonters 2020 report that should be released in the middle of June sometime. There's other population level health status reports, the disparities report. There's white papers, data briefs, program-specific reports. And then we do a lot of reporting for our specific federal grants to the CDC, HRSA, FDA. Data is on the web. We get a lot of data requests.
We
You
do.
may be able to speak to that a little.
We maintain a database of all the data requests we receive externally, meaning external from the state government. We provide support to all departments, Dale, DCF, everyone that needs support. But external to the health department, in a given year, we receive somewhere around, on average, 250 to 300 data requests from different individuals, organizations, communities, et cetera. So that's a significant portion of our time is responding to community requests.
Rich's section also is involved in evaluation. A lot of the evaluation that goes along with our federal funding, we need to do program evaluation. But I listed here a few examples that Rich had shared with me, and I don't know if Rich, if you want to provide detail, or if you want me to go ahead and do it.
Certainly, I can mention one or two
Yep.
if you want to as well. So, for example, our PRAMS program was involved with doing outreach to women in terms of multivitamins, and we did an assessment as to did they take up the vitamins, did they continue to use them, how did the marketing that we did influence their continued use of the multivitamins. This all in an effort to reduce birth defects. So that's a project that our team did internally. It didn't require external support, and it actually provided quite a bit of guidance to the health department program going forward if this was a good use of resources. So that's the type of thing we can do in a quick, short turnaround with our own staff.
And Rich shared an example of alcohol use during pregnancy also, and I thought it was really interesting, the results of that analysis, just looking at the age of a woman and the education level, and just looking at, for the younger, less educated women, focus really needs to be on the binge drinking before pregnancy, and for the higher educated, older pregnant woman, it was more actually consuming alcohol during pregnancy. And then evaluating what the best impact would be based on our survey results, and determining that if a provider actually tells a woman not to drink during the pregnancy, it makes a big difference. So, and that's helping us determine how we're going to move forward, working with all of the providers in the state and with our educational messages. So, the immunization registry, we're able to pull information about the immunization status of Vermonters. And I know a couple of years ago, in addition to programming, it was used to determine where we should put our staff resources, looking at which areas of the state had the lowest level of immunization. And as a result, the immunization program placed a public health nurse, an extra public health nurse in the Barre district office, because that was an area that needed extra focus. So that's a real quick overview. Do you have any other questions that have been asked thus far?
Actually, I'd just like to ask a question about the cancer registry. So what's in the cancer registry? Is it all, anybody who's been diagnosed, data on anyone who's been diagnosed with cancer in the state? Or?
It's any Vermonter who's been diagnosed or treated, so we collect both diagnosis and treatment data, including not just if it occurred in Vermont, but say they went to Dartmouth, Hitchcock, or Albany, or somewhere else. We have agreements that that information is sent to our registry as well. So we have that on all Vermonters, all ages. It contains, I think, over 500 different variables at this point. And we do expand in terms through rulemaking. We've had to expand the definition because there are new types of cancers, etc.
And Richard, is this playing into the oncology project that you're working on at all?
Not, well, I mean, all the diagnosed patients with cancer would go into the registry, but I'm not aware that we're using the registry at this point.
I mean, we have agreements with the mammography registry and other groups to also exchange data and make sure we're not missing any reports. But no, I'm not aware of any current collaboration.
Might be interesting to look at just in terms of controls, you know? Okay, thanks.
What are the, were you finished? I'm sorry.
Yeah, go ahead.
Okay, what are the three worst data pieces that you've got, either by difference from national standards or trends or whatever? What are the things that are really jumping off the page at you?
There are areas where we look or perform worse than the national.
Yes.
Binge drinking is definitely one that's been brought up in many of our reports, that we do have a significant difference with Vermonters with binge drinking compared to the rest of the country. Certainly during the legislative session there was discussion about vaccination rates, and that's been discussed already.
Yeah.
There, in terms of marijuana, smoking, there's a difference, again, with Vermont compared to national. But there are areas where we look very, very good compared to national as well. But those typically are items that come up quite often in conversations when I'm at national meetings.
Yeah. Thank you.
When we, at the department right now, I'm leading a group of external stakeholders as well as internal staff to come up with a state health improvement plan, which is looking at all of the healthy people indicators, which was narrowed down to 85 healthy Vermonters indicators. And we wanted to narrow that focus even further to the areas that we wanted to put special emphasis on. And it covers the things that Rich just mentioned, but we're really focused on chronic disease prevention, so it would be physical activity, nutrition, and tobacco use. Substance use is the second big category, and then immunization is the third big category. So we're right in the midst. We've just defined these three areas of focus, and then we are going to move forward working with all of our partners to determine evidence-based interventions that we all can buy into and all move forward with together to make an impact.
What role does pure old human relationships play in those interventions?
Human relationships between the partner organizations?
No, relationships between the person that has the problem and anyone else.
I think, I don't know the answer to that question. I think that we rely a lot on the evidence base, and there are some sorts of interventions for physical activity that may rely on that interaction, and then there's other policy level changes that can also make an impact. So I think you need to look at the whole continuum, and we rely a lot on the CDC, SAMHSA to help guide us in which direction and which interventions are going to be the most effective.
I think there are a couple of excellent examples, one being in the tobacco side, where especially with students, the peer relationships there play a huge role in reducing smoking among teens or preventing them from starting smoking. Health departments had a very successful relationship with the schools and Department of Education on this. The OVX public service announcements you've probably seen in their activities have made a huge difference. So I think especially with young teens, preteens, the one-on-one relationships can play a big, big role.
The physician surveys are done every year, right? Once a year?
The physician surveys we do every other year.
Yeah, okay. Kind of go along with the licensing process. And that's, let me just make sure I understand this. That's the packet that goes out with the medical practice board's licensing. So you have a high response rate?
We typically have to follow up with about 25% to still obtain their information. Which is actually, compared to other states, our response rate is the best in terms of getting a response from physicians.
And with the follow-up, you get full compliance, or?
Every time we've done it, we've consistently have had one or two who do not respond even with the follow-up, which is beyond any other state's experience.
Yeah, I know why. I mean, at the beginning, we felt like if we didn't fill it out, we wouldn't get our license. So it was really a strategically
Let them keep
effective.
thinking that.
Yeah, effective move. And then I think the
Don't
word
blow it.
the word got out that, well, maybe you still will get your license if you don't fill out. But most of us still think that, which is great.
The nice thing is for the last 8 years, it's been the same individual who does the follow-up on the missing ones.
Yeah.
So when they hear her voice, they're, oh, I forgot to send it in. Oh, I'll get it to you. So it's the personal relationship, and the survey comes in fairly quick after that.
And that's a pretty extensive survey. It's got specialty, percent FTE, location of practice. It's, and some
It
questions.
does.
Yeah.
We have found, though, that it's important to look at the specialty because that's where there may be some changes coming up, especially with some physicians approaching retirement age in specific specialties. So that's why it's somewhat of a lengthy survey.
So I'm as a nurse, I know that the response rate for nursing has been quite low on those surveys, and so I guess we need to instill more fear in nursing. Is that the goal?
And also, besides physicians, we also do the physician assistants and a couple other specialties, but we don't. The health department no longer does the nursing.
Right. So, Rich and I discussed some ways that the health department could help support you in your roles with the Green Mountain Care Board. And those are listed on the next page. There are 4 different examples, which may not be totally exhaustive, but it was just kind of what we came to just preliminarily. We can assist with collection of statewide and sub-state data from a variety of sources, and I think we already mentioned adding questions to Breathless. And that's already happening with Blueprint, correct? Is that-
Yeah. So no, this would not be anything different than what we currently do.
And then expand our current reports to include a selection of additional analysis that you may want with any of our other reports that we currently are collecting and monitoring. We could involve Rich, our public health statistics section, in planning activities as an advisor, since he really is the expert in all of these data sources. And then also, we have a lot of expertise in this section on, survey design and methodologies, evaluation, those sort of things, and that is something that the health department can certainly provide some help with.
Do you have, Rich, a simple summary of the purpose and kind of an abbreviated version of what the questions are and where they're Vermont, where we've made them up versus where they're a national?
I do, yes. We keep an inventory of that year to year so we can track when we collected something.
Okay, cool. Could you send that to me or to Georgia or?
Well, you send it to me.
You send it to Georgia, it's more likely to get somewhere.
So you could expand the physician survey as well. You could.
We could.
For
Yeah,
us-
the questions on that are not mandated by any source, so we can adjust as needed.
For us to know how much my colleagues around the state actually know about healthcare reform and, what the future holds. So, okay.
And one of our, reasons for listing a couple of these suggestions is we also want to make sure that we're all utilizing our resources appropriately. There's already analyses that my group does in terms of utilization of services at hospitals. We do much of that for Blueprint. Certainly, I wouldn't want to be duplicating something
Right.
that another group is doing or
Right.
that you would want them to do.
Okay, thanks.
So the next section of of this discussion is really just a recap of the overview of the quality coordination stakeholder interviews that happened last fall. As a result of interviews with multiple stakeholders throughout the state about how to coordinate quality, 10 different recommendations kind of surfaced. And they're listed here. I think there's a few that are more pertinent to this discussion. I heard loud and clear from everyone that it would be really awesome if we could identify 4 or 5 quality goals that we all could focus on together so that it's not all fragmented. The other piece that was really a strong opinion of many that I interviewed was that we need to have very consistent public reporting measures so that everyone's not reporting out on different things and no one knows who's collecting what. And then the other thing that is addressed in probably 3 of these different bullets is just that a lot of people said we don't know what other people are doing. And we need a way to make sure that everyone is aware of all the quality initiatives that are taking place so that we can build off of what someone else has done and we won't be duplicating. And then the other big piece that I hear about a lot, and I think it's probably improving just with access to data, but it's still difficult to get data at times to really plan and evaluate what's going on. And so those would be areas that we would like to see focused on. And I think that as Kathy starts to talk about what she wants to cover, I mean, she has thoughts even taken from the national level on how to make some of this come together. So, and unless you have questions, this is a good time to segue right into what Kathy was going to share.
All right. Any more questions for these folks? All right, thank you very much. I'm sure we're going to work together a lot in the future. Appreciate you doing that.
Will you be staying so we can ask questions at night?
Yes, we will.
Great.
Okay, and Kathy gave us this folder. Would you like to be called Kathy or Kathy?
Kathy's fine. And I'd like to introduce my lifesavers in the room. Our 2 staff, April Cochran and Patrice Stanton from Pennsylvania Quality of Healthcare, and our 2 board members, Sharon Wynn and Peter Albert. So as the newbie in the room, if I need to throw out a lifesaver, I may take advantage of that and appreciate their support.
And Peter's still chair of the board, right?
Yes. And I'd like to thank the board for the opportunity to come and present BPHQ and its current portfolio reporting and evaluation. This was a perfect segue with Deb's presentation because BPQ, through our 9416 contract, takes some of the initiatives that they've targeted and identified and takes it to the next level of work through the BISHCA contract, which is in its final stages of transitioning from BISHCA DFR to the Department of Health for all aspects of the contract. Right now there's 5 major activities. The transitions of care projects that work with the mid-sized hospitals for hospital-specific performance improvement projects directed toward the reduction of readmissions and appropriate transitions and improved transitions at discharge. There's another piece of that.
Kathy, can I just stop you for a minute? Because I'm not sure everybody on the board is intimately familiar with what BPQHC is, and it might help to do either to have you or Peter do a little bit of background on what the organization exists to do and where it came from.
Well, the BPQ started in 1988 and under the Vermont statute as a peer review confidentiality organization, commissioned with reviews of performance for physicians, healthcare quality, service delivery across the state, ensuring compliance with established guidelines, researching and developing guidelines back in the early days. It's now continued to transition into support of transformational change. Certainly would like to, probably in the process of revising some of the strategic goals to transition to healthcare reform and more contemporary activities in quality and performance improvement in healthcare. but it has a long history here in the state of Vermont. I'm a very proud new owner of the organization, and look forward to the opportunity to continue to move it to the next level. So any other questions about?
Thank you.
Sure. In addition to the transition of care projects, we have the Act 53 hospital reporting project known as the Hospital Report Card. We're in the final approaches to the finish line for getting the new information posted. That includes indicators from nationally distributed from the Center for Medicare and Medicaid Services, the Alliance of Healthcare Research and Quality, the CDC, and the National Health Safety Network for performance indicators, including nurse staffing, multi-drug resistant organisms and central line infection prevention, healthcare acquired infections, volume and mortality data, and CMS readmission and mortality rates. Another project through the 9416 contract includes the Common Physician Measurement Project. Our board member Sharon Nguyen is very involved in directing the activities. That started with a pilot for the pediatrics, looking at 3 HEDIS measures: appropriate testing for children with pharyngitis, appropriate medications for children with asthma, and appropriate use of medication for children with upper respiratory infections. In looking at these measures and establishing a process, it gave us the opportunity to identify some of the issues with getting good, clear data, focusing on the initial pilot and having the growing pains that we experienced, and now fixing and moving forward and reinvigorating the project again. We've also convened radiology and ED directors for the variation and utilization of imaging studies, redundancy and overuse for patients being transferred, a lot of good technical work in hurdling basically technology and IT issues in delivering tests that have already been done without having the need to repeat studies, both for patient safety and cost.
Could you just give me a better sense of, you do the report cards, you see the results, what happens then?
We're actually in the process of probably redesigning and reformatting the hospital report card format, because right now it's disjointed. There's cost information, but it's separate from performance information. We're going to look to Department of Health in the next year to make a thoughtful transition to a new format, more integrated, meaningful.
Let's pretend you have a new format.
Okay.
And you see the results. What happens?
If there's very wide variation, we'll start a process to talk to the leaders for that organization, specifically what makes you different. Both ends of the spectrum, in a very positive sense, what makes you so different as an excellent best practice.
Can you go,
Center for Excellence.
I know you're brand new, really, but can you look back and see that the process actually resulted in change?
I think as you start to put comparative information together, and I think that's where we want to go with a new format for the report cards, where you stand in the lineup becomes very important in terms of your reputation in the community and wanting to fix your own performance in areas where
I understand that. Have you been able to see change as
So
a result
actually,
of the
if I
process?
could just jump in, this is the first time VPQHC is actually doing the hospital report card.
No,
Prior to this
no, it's
year.
not.
Yeah, it is. Prior to this year, Bishka did it internally.
Oh,
The
Bishka,
healthcare
okay.
administration did it internally. So I think there's,
I got it.
so unfortunately, I don't
There's a
think she
break
can
there.
answer. There's a break.
Okay, my
But,
apology.
but I think the general notion of
Yeah.
reporting to providers and then acting on it, the whole
Yeah.
plan, do, check, act. I mean,
Exactly.
the organization, now I'll go off on a little advertisement because I love VPQHC. the organization was really founded around the principles of continuous quality improvement and sort of industrial process improvement. And there was a whole cadre of people, including Don Berwick nationally, who were trying to implement that. And I certainly saw in my years there numerous examples of where we would pick out a clinical area because we saw wide variations, C-sections, use of perioperative antibiotics, yada, 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 down the list. Focus with the clinicians on how to get more detailed data, redesign their process, recheck, and see whether they improved. And it did improve. I'd say the weakness in that model was as soon as you stop looking at it, sometimes, not always, but sometimes it stops.
Yeah.
You lose some of the
Right.
ground you gained, number one. Number two, oftentimes, as we've talked about so much in our discussions, the financial model that would support doing the right thing
Isn't there?
wasn't there.
Right.
So,
They-
end of advertisement.
This was a good side trip, so appreciate it.
Absolutely.
Yeah, okay.
Absolutely. And I think in reformatting the hospital report cards going forward would exactly want to bring those characteristics forward and make it much more user-friendly for the non-clinician, the community at large. And, you know, more user-friendly, more information in kind of one-stop shopping. And finally, our last activity under the 9416 contract is where our roots reside in peer review and maintaining a system of technical support and advisement for you know, physician peer review situation and implement improvements to individual practice. We have other BDH contracts. We have a contract for the Healthcare Acquired Infection Collaborative, very successful, recently concluded 3-year project with national recognition for Vermont. We have a sponsored seat to the HAI Data Summit. Excellent work that was done in collaboration with hospitals and long-term care centers. Very effective tools and implementations that were initiated as a result of that project. We have ongoing patient safety surveillance, which is the hospital serious event reporting system. We provide mentoring and advisement and support to the hospital quality and safety staff. Flex, readmission and transitions contract, similar to the other transitions contract that I discussed for the mid-sized hospitals, but the Flex contract is specific to the critical access hospitals. Again, hospital-specific QI work to reduce readmissions and improve transitions of care. We're now moving into the second year of a 3-year contract for that delivery. The New England Rural Health Roundtable and its Performance Improvement Division, NEPI. We work with BDH in representing Vermont on the New England Rural Roundtable. We have a consultant that provides condition of participation readiness surveys to the critical access hospitals, works very closely with the critical access hospital staff in informing them of potential areas for citation and really giving a good support and direction in preparation for their COPS surveys. We also recently worked with NEPI to recommend sponsorship through the New England Roundtable for 30 professionals currently in the quality field to pursue their certified professional healthcare quality examination with 30 fully sponsored seats to include the cost of materials, registration for the examination, and the study course. The intent is to raise the skill set of the staff in the critical access hospitals who struggle with QI concepts. They're new to the job, they wear multiple hats in that role, and this will strengthen the skill set. As a result of some of the work in the transitions projects, we've just seen a skill set deficit that can be easily corrected. We have identified several staff members ready to go for the 8 sponsored positions, plus an additional 6 or 8 candidates that will take advantage of the NEPI discount for the examination. So that's very exciting in terms of building the ranks of the QI staff across the state. The final additional contract is the DNR and COAST, which is the Clinical Orders for Life-Saving Treatment contract, collaborating with BAHA, BICA, and BEN, the home health, the long-term care, and the Vermont Ethics Network to create and disseminate the education surrounding the use of DNR orders and COAST information. This information is going to be posted as a skill learning set on the IHI website. VPQ has sponsored 50 accounts to take that certification and receive a certificate. And we're also going to utilize the same training and post it on our global classroom platforms, which I'll explain a little more in detail further on. We have a contract also with the Department of Corrections. We provide medical record reviews and root cause analysis for their serious event reporting, in addition to supporting their development of corrective action plans and the necessary tracking for those events. We've provided them with a preliminary scope of work document for the psychotropic medication use in the detainee population in cooperation with the Health Services Division of the Department of Corrections. We're hoping to gain insight into the prevalence and utilization of psychotropic medications in the prison system, with the implications, again, for transition upon release. So this is very important work that's just beginning that will be very beneficial in many areas. Our latest project is a collaborative grant that we've submitted a letter of intent to CMS with long-term care. We're cooperating with the Department of Vermont Healthcare Access and Disabilities, Aging and Independent Living, and the Vermont Healthcare Association and the long-term care facilities to hopefully have a successful grant application for the initiative to reduce avoidable hospitalizations among nursing facility residents, addressing the dual eligible Medicare and Medicaid long-stay nursing home residents. The method or the model we're looking to pursue is advanced practice nurses, nurse practitioners, and purchase of DME to prevent the long-stay residents from having to be shipped off to the emergency department at 11 o'clock on a Friday and kind of treat in place, especially beneficial for the demented elderly population and long-stay residents. In addition to all those projects, we support the projects through the organizational expertise that we bring clinical nursing, quality improvement specialists, an epidemiologist, and we have extensive experience in informatics, education, communication, project management, data management, and analytics, finance management through our Director of Finance, and we provide mentoring not only for our professional colleagues, but interns and a VISTA volunteer as well. So that's our current book of work. Any questions?
Well, I'd just like to make a comment because I think VPQHC has always struggled on a couple of fronts. One is the sort of public versus private. It has the peer review protection, which is really important in terms of getting clinicians to engage and feel comfortable that they can look at data that might show them to be an outlier and discuss it with appropriate protection from public discovery, versus the sort of need to show the public what's going on and that you're assessing quality in the system and providing some accountability. And I think that tension's always there. And it seems to me like right now the focus is more, at least in terms of what's getting out there into the public, it's more on the specific interventions that are less public, less about the public reporting. And I think some way of connecting the specific interventions with a broader framework and broader strategic goals is going to be really important to providing that sort of accountability that is necessary for folks like us, other policymakers, and the public generally to know the reason you're doing these umpteen things is because they connect with goals that we really care about, and there's some level at which you can show us it's connecting and making a difference. So I think that public-private tension is always there. And then the sort of big picture versus specific interventions, like what are what are those big goals and how do they connect with, why do you choose this list of stuff versus some other list of stuff? So often I think in nonprofits you end up doing it because you're chasing money. And that was, certainly when I was there, that was a tension, because you want to focus on what matters the most, but you also have to pay the bills. That was part of the reason for providing for public funding for the a big chunk of public funding for the organization. But somehow still connecting the specifics with the large goals, I think is really important in terms of accountability for the public funds, certainly.
Absolutely, that's a perfect segue. In thinking about the presentation to the Green Mountain Care Board and what's important going forward, to understand and use a document like the National Quality Strategy, which, there are 3 aims: better care, affordable care, healthy people, and healthy communities. To use that as a structure to hang all of our identified needs, movement in healthcare reform, many big goals to increase more covered lives, improve the quality, and reduce the cost. So having a national structure to follow as a roadmap is a first step, I think, in a plan to coordinate all the data that's available, using some of the metrics that are mentioned in or described in the National Quality Strategy to certainly help organize the effort.
Right. So before you dive into that, I just want to make sure that other folks didn't have questions or comments. No? Okay.
The National Quality Strategy was kind of commissioned through the Affordable Care Act and the Federal National Department of Health and Human Services with developing the National Quality Strategy. The National Quality Forum convened a national patient partnership, and there's a listing included in your materials of 48 public and private sector partners provided their collective input for an original document that was released a little over a year ago. Further refinement on that document came recently, just in the past winter season, with the release, I think it was this past March, to develop more actionable and measurable goals, specific objectives with rationale and actual measures to follow in each of the 6 priority areas. In the National Priorities Partnership, some of the notables are AARP, the Institute for Healthcare Improvement, the Institute of Medicine, of course the National Quality Forum, and the U.S. Chamber of Commerce is one of the 48 partners as well. Using the framework helps accelerate improvement. It's a catalyst for health and human services. The stakeholders identify opportunities for action and alignment with the national strategy. It engages others to advance the priorities and goals as lined out in the national strategies. It accelerates change. One of the quality principles is rapid cycle, Plan, Do, Study Act, Plan, Do, Check Act. In terms of healthcare reform, 2 years is rapid cycle for turning a major shift in a new direction. So using those principles of change with this national framework would be very beneficial. It helps to develop strong private and public partnerships and adoption of shared goals. On the dashboard descriptive area, it just gives the 6 national priorities and the rationale underneath, so with everyone's buy-in, you can maintain a course. You establish responsible members in the community and as partnerships in the advisory committee of the Green Mountain Care Board for accountability of improvement in those measure areas, and promote the ongoing multi-stakeholder collaborations. As I've said, the National Quality Strategy becomes the roadmap. It engages the stakeholders to develop a community-based plan that fits Vermont. And VPQ can lend the project management expertise to guide and develop the ongoing support to keep the objectives in sight and on track. With national quality strategy as the architecture, the Green Mountain Advisory Committee then becomes the infrastructure at the local community level to advise the Green Mountain Care Board and their activities with ongoing payment and delivery system reforms, emphasizing primary care that brings, rewards value over volume. These are all the efforts that have been initiated by the Blueprint and supported through VITAL's integration of information technology, demonstration grant efforts, and integration and continuing focus on the underlying cost drivers. In implementing the National Quality Strategy aims, used underneath the structure of the advisory committee can be technical work groups to start to develop dashboards and metrics and information available using the data through all the sources that are available across the state. A second aim would be to educate providers, payers, and the public concerning healthcare reform, carry the message of the National Quality Strategy and the local plan forward, and that with the dashboard development, data drives the decisions.
So are you suggesting a new, different advisory committee, or are you suggesting that we use our existing general advisory committee?
Existing. And probably support the existing structure with smaller work groups to bring forward a selection of metrics for population with data and analytics in alignment with the National Quality Strategy document.
Kathy, did I miss it, or have you mentioned what the 6 priorities are?
You know what, I have not.
Okay.
I accidentally removed that slide, but if you
Or
look
just
at
an
the
example
making care safer, they're listed on the front page.
Health and well-being.
Health and well-being, affordable care. I'm
Health and
sorry, I
well-being,
pulled that slide.
prevention and treatment of leading causes of mortality, person and family-centered care, patient safety, effective communication, care coordination, and affordable care.
That's what she said.
There we go. Thank you. In project management tools and efforts that we can follow up with, you assign an owner or champion of the specific measures for improvement and accountability. So in addition to selecting measures, you select someone to take responsibility and ownership of that through the work group and technical advisory committee, support improvement activities based on the identified needs, looking at the data that becomes available and prioritizing activities to go forward and help identify successes in pursuing the healthcare reform initiatives. All of this provides status and progress reports to the full Green Mountain Care Board. The purpose of the work group, Deb did a great job introducing the concepts that were brought forward as a result of her stakeholder interviews in enhancing the coordination between government and non-government agencies, the payers, healthcare facilities, and providers to determine the focus of the quality initiatives. In addition to the coordination, increasing the awareness of everyone at the table, healthcare facilities, providers as well, in the types of quality initiatives being, probably types and volume, being implemented across the state. I think, as a new person, I learned just from hearing Deb's presentation things I haven't come across yet. So there's a wealth of information now. It's a matter of coordinating it in a meaningful plan. Manage and disseminate the implementation of best practice interventions, utilization of project management support, and oversight of all the activities, and increase the agency's use of one another's websites to share training, evidence-based resources. We have signed on with Global Classroom, purchased 2 platforms for educational information. One will be dedicated to professional services provider level, more technical information for sharing and dissemination. Another platform that will be geared to the individual consumer and starting to build consumer education around healthcare reform. So those, we're in the process of finalizing the documents and training, and we'll be posting information very soon. The Coast education, the DNR Coast education that will be posted on IHI will also be made available in that professional platform through the Global Classroom.
I should have asked this before, but what's the C for in Coast?
Clinical.
Clinic. We had Pulse, then we had Most, now we have Coast.
I think in New York they have MOLST.
Yeah, that's what I'm familiar with. Massachusetts
Massachusetts
is
has most, but
Most.
the M's for Massachusetts, because they're self-centered.
Well, then why don't we have Volst, except that it sounds stupid.
I think in Jersey it's POLST.
Yeah.
We could have Gomolst.
Come on, Volst.
Yeah, Green Mountain Most.
Carry on.
So the work group tasks would be to
That's why,
develop.
that's why that shouldn't be right there. And I'm looking at my attorney, like, that can't be good for me. That should be, Walter, like in his pocket. There's nothing illegal about it. All right, good.
So the work group tasks would be to develop the performance dashboard. What was put in your packet is just a sample of measures straight from the National Quality Strategy. Information that would be available to populate a performance dashboard, populated with the most current performance data that's available. Again, learning more sources of information that are available and utilizing all the local talent to pull that forward into an organized structure, providing the analysis and recommendations to the Green Mountain Care Board, and then report the findings and identified need areas and progress towards those dimensions.
So, Kathy, you've got a lot more detail here, and what you're getting into, I think, is something that's going to require a fair amount of discussion between us and you. We're already partway down the road in terms of developing a very high-level dashboard. Con's been working on that, and we have Cy Jordan under contract to do that. And then how that fits into our structure of advisory board, et cetera, I think probably should be, I think there's some good idea there, and I think it probably should be pursued at a level that's not appropriate for our meeting in terms of just the detail and all the, what are you doing now? How much space do you have in your portfolio? How can we start to meld our efforts together? So I would suggest that rather than going into a lot more detail on your suggestions, we
I'll set up
we punt this to Georgia and to Con, who's been taking the lead in this area, and ask them to work it through with you and figure out what makes sense for the future. And I would ask you if you might just sort of hit on, aside from that detail, whatever else in your presentation you want to hit as the high points before we go to questions.
Just probably a main focus that we would also like to pursue is the patient engagement area. Starting to really populate the consumer side of the Global Classroom with health literacy programs to go into the schools and start to educate young folks so they understand the complications of binge drinking, and then understanding Know Your Numbers. There's a national program called Know Your Numbers, and the relevant meaning of having low cholesterol, good triglycerides, BMI that's acceptable, and then translating that information and bringing it home. So several patient engagement and education in health literacy activities. That's developing business partners and within the community, and to reiterate Deb's request and several of the requests in other presentations for real-time, current, up to the minute data. We're signing up for that lineup as well. BPQ would love to partake and be able to produce analytics that will feed into all the initiatives for the Green Mountain Care Board and the state.
We all want it. We're working hard on it. The Holy Grail. Yeah, this last area of patient engagement I know is of great interest to some of, or related to some of the areas of great interest to Karen as well. So I think there's probably some discussion you guys could have about that. But I know it's an area that is screaming for attention. Well, thank you.
My only question is around capacity, meaning like if there's so much in here, how much of this is possible starting tomorrow at 8 a.m.? And I don't really mean that to be funny. I mean like what, you know, there's so much talk about what if, what could, what should, but yeah, what, you know, what could be available by when?
Well, in terms of some of the measures that I put into the sample dashboard, focus on preventive care, looking at ambulatory care sensitive measures that, you know, ICD-9 codes that could be treated outside of the emergency department, making sure those are staying within control and decreasing over time. Being able to access the real-time data to support that, that's our hurdle.
So
That's our
with the
current
data,
hurdle.
you could do a lot.
Yep.
Everybody.
Seems to be the theme.
Yeah.
Someone's gonna walk in someday with a big suit on called Data. And be like, oh,
Yay, there you go.
you've arrived.
Karen. There are certainly some very appealing aspects to going along with 6 nationally identified priorities, and it'd certainly be interesting to work with you around the details. Because I had sort of 3 more general questions. One was around the timeline as well. So when often we've tried to work with national efforts of various sorts, we're sort of ahead of the curve in some ways. So it's kind of hard to wait until the nation is ready for where Vermont's needs are right now. So one question is just in terms of not just what's ready to pull off the shelf, but when you're working with this number of partners on a national level, going forward with actionable items sounds like a very tall order. So my first question of the 3 is, what do you think is going to happen in terms of timeliness on some of the next steps for the collaboration?
Well, if a work group, I know there's a data users group meeting later this month, that if that group can get together and hammer out some of the technical details around data flow and the available data, to be able to start to take that and designate a small technical advisory group to
But
start.
you're talking more at the state level, you're talking about this group at the national level.
Yeah,
right?
to this
I think
dovetails, I mean, certainly the 3 overall overarching goals, no problem. The 6 don't look bad, actually.
Yeah.
Surprisingly good in terms of the preliminary dashboard that and others have been working on, not bad. But now when we get to the actionable items.
There's a listing of probably over 60 measures included within the National Quality Strategy that we can pick and choose.
But we wouldn't have to wait on the national efforts to.
No, we would
This would
find.
be a framework for our effort, but we could go full speed ahead and not wait. I
Exactly.
think that's what you're
And,
suggesting.
and select the local needs based on,
Right.
on information from Department of Health analysis, where we currently stand a little bit different than, you know, do some more detailed work to pick the priorities we want to focus on, including the affordable care measures, health spending per capita. That's where we may start to see some movement related to the efforts of the healthcare reform area. So target the areas that we make sense to make sure the shift is on to preventive care from high utilization hospital care.
And then just the other 2 quick questions are, looking at from sort of the Green Mountain Care Board activities point of view, another thing that we're charged with is a unified health budget. So I'm wondering how you might think about where exactly this might fit in terms of constructing a unified health budget. That's one. And the third one is, similarly, we're looking to the blueprint, but other delivery system and payment reform pilots. So how would you see this exactly working? In one of your bullets was that the nation's approaching this as a learning health system model. So we are too. So how would you see in those 2 instances, the unified health budget and the payment reform pilots, being able to use this in real time?
Well, probably for the pilots, determine metrics that will be consistent across the 4 pilots to see where the most efficiencies are gained, where the cost savings can be shared across all the settings to make sure we don't want to undercut hospital budgets that will then compromise the available services for the higher acuity to reinforce their payments so that they maintain their appropriate level of services without overuse, and finding the metrics to strike that balance. But take metrics that can be compared for the 4 demonstration pilots consistently.
I think of it as, value equals quality over cost is what we always used to say. I think you've been driving us into value equals health over cost. And maybe there's some dynamic between quality and health that's actually the numerator. But that perhaps VPQHC could have a role in helping us define the numerator in that equation. Yeah, thanks.
I just want to say that I was privileged to be on the hiring panel for Kathy.
Good job.
That wasn't my point, but I'm really, frankly, thrilled at how quickly you have grabbed this whole thing. It really, we're in good shape right now. So thank you.
Thank you very much.
Yeah.
Thank you for this opportunity. Thank you.
Alan, any questions?
I'm all set.
All right, thank you so much. So we will, as I said, punt this to Georgia for follow-up. Clearly, there's a lot of work to do to follow up.
That's absolutely.
All right, thanks a lot.
Thank you very much.
Okay, at this point, do we have any new business? No new business. Any public comment? Yes, Peter?
Hi, Peter Albert, Brattleboro Retreat, the chair of the board of VPQHC. And 2 things. One, quick comment about the prior presentation from the health department and Kathy. When there are surveys done for physicians, and this may have been said and I may have missed it, but particular to mental health and addiction, with the lack of psychiatry time in the state, a lot of the health plans have now allowed APRNs to do prescribing. So when you're thinking of succession planning and surveys, it would be worth, if you're not already doing it, to start factoring them in as well. To VPQ, just speaking as the board chair, the last couple of years, the board has done a lot of work internally to revamp itself and reorganize itself, which has led to reorganizing the program itself with the hiring of some really excellent staff. To your point, Anya, the 2 points that you hit on that the board consistently talks about and has charged the new staff to deal with, which is be very cautious when you define projects, that they don't just go off by themselves, that they have to fit into the bigger picture and they have to be connected to other services, and that don't walk away from the tension between public and private. Actually grab hold of it and take the lead on it. Because there are ways of having difficult conversations that lead to productive outcomes when people are willing to share data in a not I gotcha environment that lead to good outcomes that will build trust and relationship. So that's the expectation from the board. And as you've heard, Kath brings great amount of focus and detail and knowledge. And I think combined with the rest of her staff who have the operational skills and the board that's going to push really hard on this, we're hoping that VPQ can be a real viable resource for you in your work in whatever way possible. And part of having Con on the search committee was a step in that direction. And we again appreciate your involvement with that.
I think that's an excellent point, Peter. I almost got fired over the Vermont Healthcare Quality Report. Richard probably remembers these days. About a third of Richard's colleagues thought I should be fired. But that's right where you should live, Kathy.
That's where I love to be.
Former colleague.
Yes. And he wasn't trying to let the record show. Any other comments? Yes.
I'm Thomas Hall. I'm working with Karen and Con on this roundtable or this discussion group on wellness and primary prevention. And my question is, how do you measure primary prevention? In other words, if something actually prevents a disease from happening, how can we track its effectiveness?
Well, visits to the primary care provider, and interesting. I came 2 weeks ago and heard the Patrick Flood, the Department of Mental Health presentation. And Al, you made a great observation as an employer and as a community member.
I don't know I don't know what to say there. That was totally, she didn't mean it.
No, but in saying, when he sees an employee going south, having difficulty, I thought that was exceptional as, you know, as a person, but then as a business owner and then as a community leader, to reach out and say, where can I get support for this individual? Where can I start to help? And in the role as a business leader, to start to coordinate efforts to have accessible recreational facilities and start to use real preventive activities, again, through patient engagement and education and health literacy, to start to work on cholesterol numbers and what resources are available with binge drinking, and how can we address these before they blow up into bigger problems, costlier problems that become a drag on the whole community as well as the individual. So one of the metrics included in the National Quality Survey or strategy said indicated recreation facilities per 100,000 population, and I thought, wow, what a great business opportunity to buff up the ball fields that have rusting wire cages as the backstops and start to engage community efforts in everyone's health overall.
I'd like to suggest another parameter you could measure is healthcare utilization, meaning actual tracking claims through the records.
Mm-hmm.
I've seen a proposal in which they're proposing to do that as a measure of the success of the project.
Absolutely, multiple metrics in targeting ambulatory care sensitive by ICD-9 codes, so that congestive heart failure, ear infections aren't being treated in the emergency department. Hopefully we'll see increases in primary care by tracking those ICD-9 codes.
Yeah, just to correct the record a bit, the meeting that Thomas referred to as a roundtable is just a very informal, one-time meeting with a dozen people around the issues of wellness and primary prevention. So, just to say that.
Thanks. Peg.
I just don't, I'm not sure if the comment belongs here, but I was disturbed, I think, last week from on public radio. They were talking about the hospital in Rutland closing down their rehab unit. And again, it brings up, I know last year that there were some questions of hospitals maybe stopping services in those areas where they're not money making, they're losing money. And my concern is when we're talking about much of this, how do we keep critical services in the community? And I asked the question at the time, is there any process like the CON process that we have to go through when, in some aspects, to look at when a nonprofit hospital decides to end certain services and stuff. So I want to raise that as an issue, because it's a real issue. Where will the people in Rutland go? Somebody was saying they'd have to go up to Fletcher Allen, they would have to go. And anyway, I don't know. I think it might fit a little bit here with the access.
Just a comment about patient input and how will that be gathered and who will be doing the gathering. As a patient, I understand this problem well, as one that's been through it. So that was just my question. Simple.
Gail Graham, sorry, this is an ongoing question, but it's kind of segueing with this, is that...
Can you say your name again first, Sam?
Gail Graham. Is, take the patient, for instance, a diabetic patient. They're not the only ones, but that's a prime example of ongoing readmissions. But as a lot of us know, it's because of non-compliance. And I know this is a difficult question and no easy answer, but I just think it's really something, I mean, I know I have it in my own family. example. And it's very frustrating, extremely frustrating, because I try to help and support, and the individual just goes, no, whatever. And I know, it's difficult, but it's a very costly situation.
I think that's where education engagement stuff is very
Absolutely.
important.
I was just thinking the health literacy and understanding that your sugar management early on prevents loss of vision and other very
And-
serious complications down the road.
I guess trying to get with the now younger generation, I hate to be negative, but I don't know that there's much we can do with the older generation that's already set their patterns and as I say, their attitude is, you know.
Set in their ways.
It's set in their ways, yes, and nobody's gonna, you know, and as long, excuse me, but as long as somebody else is paying for their health care, then, so. But yes, with the younger generation, it's extremely important.
All right, thank you. No other comments? All right, thank you all for coming, and thank you to our presenters. That was
Yeah,
great.
that was a good day.
Oh, that's too funny.
Thank you.